So this actually, I think, is interesting that we talked about POEM this morning, because I think if POEM is ultimately going to become a mainstream treatment, we're going to have to follow similar pathways to introduce this into practice. We're talking about a lot of this has to do with novel techniques and technology as they infiltrate surgery and the way that we adopt them, incorporate them into practice. And then for some of us, this talk is going to come full circle, and we're going to end up a little bit back where we started. I have no disclosures. The objectives for this talk are to understand the history and purpose of FLS and FES in terms of surgical training and credentialing. And then we're going to look at future directions for surgical training, credentialing, and the evaluation of surgical competence. As an outline, we're going to try and set the stage for you, and then we're going to talk about FLS, we're going to talk about FES, and FEC, which I'm going to interchange. It always happens when I start talking about this. They have a lot of similarities. And then we're going to talk about some future directions, some existing programs, some developing programs, and maybe even what some future programs are going to be. So in setting the stage, what I'm going to try and convince you is some pretty easy connections to make. That if you train people to do something, they generally do better. Pretty easy, right? And that if people can do better with training, that translates, or in a simulator, that translates into how they perform in the operating room. Also pretty easy connection to make. And that people that perform better in the operating room, that does translate into patient outcomes. And I think deep down we can all sort of agree with that, but seeing some data that helps to support it would be useful. So this first study that I'm going to go over, I think, is really interesting. And this was a meta-analysis done by Cook in 2011. And basically, they set out to answer the question of to what extent does simulation improve training in healthcare versus no intervention. This is a classic education research study. And then secondarily, they tried to figure out what was it about these simulation training exercises that actually made a difference. And so they identified almost 11,000 studies, and they refined that down to over 600 that dealt specifically with this area. And when they pulled those off, what I want you to pay attention to really is, you can't see them, but it's the right-hand side of this line. So the line is no difference. And to the right of that is a tendency towards or favoring simulation. And so in terms of knowledge and time skills and processes and products and behaviors, they all favor simulation strongly. So hopefully this makes the argument that simulation training versus no training is better, and that makes sense. They even ultimately found in small groups small to modest patient effects. We'll get to that. So I actually heard Dr. Cook talk. He was part of a conference that I was at about a month or two ago, and he was basically pleading with the audience to stop doing simulation education sort of research, the standard stuff, looking at no intervention versus intervention. We know it works. And when they actually looked at this data set, this was set in the first 5 or 10 studies that were done. We didn't need to do the remaining 600. And so when we actually look at the other things that they were trying to get out of that data, of what is it about a simulation session or this training exercise that makes a difference in terms of outcomes? How do we improve value? So what is it that we should focus on when we develop these programs? They were essentially unable to really find what it mattered. So 600 studies, all this effort to prove the same thing we already knew, and we didn't get any more progress from it. So essentially his plea was, let's start looking at how we can actually make things better. So this is a slide I'm going to steal from my FLS component of this talk, which basically takes us to that next step, which is saying that if you teach that those skills that are acquired with a simulation exercise are transferable to the operating room. So this comes out of the validation that they were doing of the FLS skills, basically saying that if as people practice or get experience and get better in the operating room, better with simulation, that translates into operative performance. And then finally, this is some bariatric data, is that with these big registries that we have collecting prospective information on patient outcomes, we're able to get some interesting information from that. So in Michigan, they found 20 bariatric surgeons who were willing to submit videos of their operative performance, their operative technique. And they cut out sort of the high stakes components of those gastric bypasses. Creation of the gastric pouch, creation of the gastrojejunectomy, and creation of the jejunojejunectomy. And then they had those videos peer-reviewed by 10 of their colleagues. And they were scored based on skill. And when they put that all together, what they found is that the bottom quartile of that skill set was associated with higher complication rates, higher reoperations, higher readmissions. So skill matters in terms of patient outcomes. Okay? Again, doesn't take a lot to convince you of that, I don't think. So let's talk about FLS. So the fundamentals of laparoscopic surgery started in the late 80s. This is when laparoscopy started. It doesn't seem that long ago, but that was when laparoscopy started. In 96, we had a program, the Mistell's program, which is the Mcgill Inanimate System for Training and Evaluation of Laparoscopic Skills. And this was a program this was some standard education research. They were trying to figure out what it took to teach people how to do laparoscopy. Remember, this is a time when people weren't doing a lot. And so that was going on simultaneously, and in 1997, a couple of surgeons got together and said, hey, we need to develop a standardized approach to training people in laparoscopy, and that's when FLS really started. It took 7 years to put that whole thing together. It seems like a long time, but that's what it took. So in 2004 is when they officially launched FLS, and then in 2008 is when the American Board of Surgery got on board and said, we're going to make this a requirement for certification, and that was required starting in 2010. In 2012, the certification, they decided that certification, like general surgery or the American Board of Surgery certification, would only last for 10 years, and basically suggested that everybody doing laparoscopy should have FLS certification. And as of 2017, we have almost 14,000 people who have been trained with this or gone through this. So this is what they found with, so now I'm going to walk through that timeline. So Mistell's, they looked at 7 tasks and they scored those for efficiency, basically, and precision. So these were metrics that they could actually follow to figure out performance. And so the graph on the right shows that they were able to distinguish junior versus senior level trainees. And ultimately what they were able to show was that this Mistell scores correlated with experience and with training. So a junior resident that invested more time in training could move up and improve performance. So this is started in, this slide is, sorry, the fonts are messed up here. In 1997 is when this started. The objective was to create a standard for core knowledge and skills in laparoscopic surgery. Remember, in 1997, these were surgeons. So these were practicing surgeons that were the target for this education program. Not residents, but surgeons. And that was needed because there were a limited number of teachers. Laparoscopy was new. There weren't a lot of people that were doing it or that could provide teachers. Most of the training was industry sponsored and haphazard, and it was really more of that C1, go to a weekend course, learn how to do it, and then incorporate it into practice. And so this was surgeons who needed to get the skill set to bring it back and start doing it at their hospital. In that time, there were more or as many open choles being done as lap choles. This was a process for verification of skills. So this was general surgeons being able to get a certificate that said that they had acquired a core skill set that was necessary to introduce this technique. Dr. Swanston and Soper really were involved, this was in 97, were involved in really getting this off the ground. They set out to establish the curriculum and they recruited help. They got Dr. Fried and Dr. Schweitzberg to help with developing a skills component. That's where the Mistell's program comes in, and they refined that down to 5 of the original 7 tasks, which are the 5 basic tasks we all know from FLS today. They developed and validated assessment tools both in or using the manual skills that were from Mistell's and a knowledge assessment as well. And along the line, part of it, what ultimately helped this get driven forward and adopted was support of industry, or excuse me, support of the national organizations, and they got funding support from industry. I'm going to skip through that one. sorry, this goes off the end. Let me see if I can scroll down on the. So what's not on here is these are just the. So now going through what FLS is, this is the cognitive component of FLS. It's basically preoperative, intraoperative, operative considerations, and then postoperative considerations. And what's off the bottom of the screen is the manual skills component. And this is just an outline for what was included in the cognitive curriculum of FLS. And then there's the manual skills, as we talked about. There's the 5 Mcgill's tasks that we all know: peg transfer, pattern cutting, endo loop, suturing with intraporeal and extraporeal knot tying. And these were developed to focus on the unique aspects of laparoscopy: monocular vision, limited degrees of freedom, fulcrum effect, and to try and develop basically two-handed dexterity in these laparoscopic tasks. And this was supposed to be an objective assessment of proficiency, and again, used to help practicing surgeons take this back into practice. This is the graph that I had showed before, is along the way in the process of validating this. So between 97, pulling all this together in 2004 when it was launched, they carried on the study looking at how those skills translated into operative performance, and this was part of that validation work that was done at Mcgill, essentially showing that Mcgill scores correlated with intraoperative technical performance assessments in trainees during lap chole. So in 2008, the American Board of Surgery announced that it was going to require FLS as a prerequisite for certification in general surgery, and that would start in 2010, and that this was part of a broader ongoing effort to standardize knowledge and training that happens in general surgery. And then at that same time, they also required the ACLS and ATLS course, 2 other standardized courses through the American College, or ACLS is not, but ATLS through the college at the same time. And so to date, it's been suggested by the ACS and SAGES that this be required for every general surgeon. And as of 2000, just last month, almost 14,000 people have completed this. So lots of data there. The modern view of FLS has changed. It still remains a process for the verification of proficiency in technical skills and knowledge for laparoscopy. It's come to be the model for education programs in medical education in terms of standardization They have a cognitive and a technical skills curriculum and validated assessments for both. It really led the way in terms of a paradigm shift in the way that we train, focusing more on goals, outcomes, as compared to just hours. So now we want to train people to proficiency rather than just say you need to do 100 of these or spend X number of time. And so the original goal still stands, which is this is to create or to establish core knowledge and skills. It's just the focus is different. So in 2017, this is a program for our junior trainees who are ultimately going to be immersed in laparoscopic surgery from the very beginning. Nowadays, obviously, lap chole is done much, much more frequently than open cholecystectomy. So this was a quote by Dr. Soper in 2014, looking back on the history of FLS, and I think this summarizes it nicely, and this is going to sort of help to tie this all together at the end, which is the dynamic nature of surgery is what makes this interesting, and even now the role of FLS is changing. And that we can see a time where 20 years from now where we're going to be stuck with this same problem, except for with open skills. And where we can see trainees who are going out, who are doing lap choles, and they're nervous when they have to open because they just haven't done that operation. It's a novel technique in a way. So moving on to FES, and this is, I'm going to apologize, I'm going to interchange FES and FEC, the fundamental flexible endoscopy curriculum, so bear with me. We're going to talk about FES and the development timeline because it really parallels FLS. This started from a little different, with a different pressure, so not practicing surgeons introducing skills, but really from the standpoint of trying to retain endoscopy within general surgery. And so in 2006, there was the ACGME ORC changed the numbers, increasing numbers in endoscopy to try and retain general surgery graduates, or to retain the endoscopic skill in graduates. And around this time, too, SAGES sort of started championing the development of FES, so the fundamentals of endoscopic surgery. In 2012 is when the ABS came out with the announcement of performance metrics, and this will be important in terms of the development of a skills curriculum that goes along with FES. In 2014, or somewhere between 2012 and 14, is when the ABS announced the requirement of the flexible endoscopy curriculum, different from FES, but different from FES, but essentially is FES in terms of that's what the requirement is. And so that was announced in 2014, and then 2018 is when we're going to actually get there as far as it being required. Again, these are going to be off, so I'll just, the slide sizing is off here, but this closely mirrored or modeled after FLS and responding again to different pressures, so the push for endoscopy. And there was a big debate about volume. So the way that we assessed or determined your ability to be credentialed in endoscopy was more based on numbers rather than actual technique or proficiency. And so the goal of this was to establish, like FLS, a standard for proficiency in knowledge and skills as it relates to endoscopy. And so they wanted to move from case volume, of which gastroenterology had more, and move towards proficiency standards. This was introduced with a focus on resident training. They wanted to establish that baseline. They started with defining and developing the online curriculum, and then they moved on to the development of a technical skills assessment. Not a curriculum per se, but a technical skills assessment. And this is going to come important, is that they chose to use a virtual reality simulator. And so for reasons of cost and availability, that's part of the reason why the curriculum isn't going to be part of this. So in 2012 is when the ABS announced they also require operative and clinical performance assessments as part of general surgery training. They didn't specify what tools, but basically this is pushing towards proficiency or goal-directed training rather than volume. So they want people to train to a certain level of proficiency rather than just doing numbers. They didn't specify the tools that needed to be used. They just encouraged that they be validated and reliable tools. The purpose of this is that these should be used for formative feedback. So we know that as you observe and assess trainees going through a program, if you can provide them with objective, specific feedback, that then they can incorporate that and make improvements. So this is just the flexible endoscopy curriculum, and this is what I'm going to start covering now. So this is technically what's required by the American Board of Surgery starting next year for certification. And this includes 5 levels. It's a cognitive curriculum. It's a manual skills curriculum, both of which really are guidelines more so than an actual product. And these culminate in level 5, which is really where the assessment comes in, and that's going to be FES, as well as some other meeting some guidelines, some subjective guidelines. So I'm just going to go through these quickly. It makes sense. Level 1 through 5 really correspond with the year of training. So in the first year, they encourage a basic understanding of GI diseases and scope manipulation that builds to understanding the endoscope and how to set it up and troubleshoot it. And really, this is focused. The initial training is encouraged as far as inanimate training, maybe VR training, but not really clinical. In the mid part of this, level 3, they want to start. They encourage residents to be involved in peri-procedural management, so talking about sedation and prep for endoscopy. And this is where they recommend an endoscopy experience really starts. So this is getting the clinical experience in endoscopy going, and that can be either with dedicated endoscopy experience or as part of other services and doing intraoperative endoscopy. And then level 4 is talking about normal and abnormal findings. And again, this is just building experience. And this is where we see gauges. So this is the global assessment tool that came out of the society, or SAGES, which helps people define when you've met proficiency. So again, this is part of that step away from numbers and time, hours invested, towards achieving proficiency. And then step 5 is really where we see the only element to this that's an assessment, and that is, so this is the guideline calls for continued training, and then the requirements we see at the bottom is that you have to meet the criteria of a surgical endoscopist, You have to meet your case numbers. Those are still in place, and those are supposed to go along with Gage's evaluations. And you have to pass FES. So what are those criteria? So the surgical endoscopist really is exactly what the curriculum spells out. You have to know about indications, contraindications, normal and abnormal finding, management of complications, and then you have to be able to do basic endoscopic maneuvers, navigation, mucosal inspection, management of tissue acquisition, so biopsy, management of complications, and then you have to be able to place a peg, or have to have sort of core knowledge in how to place a peg. So that's the procedure association. This is the Gage's tools. This is a global assessment. Again, it's simple. 1 through 5, this is just a global rating scale. So an expert or your attending is supposed to watch you perform these skills and essentially then grade you on your performance. Again, going towards a goal-directed learning, and the objective is to reach a score of 18 consistently in cases. It's simple. They've demonstrated inter-rater reliability and its validity. It can be used with any of the training programs, which is important as we talk about the curriculum that goes along with the flexible endoscopy curriculum that's required by the ABS. It can be a formative tool, so it can be used for improving performance, and it's generalizable. So now we're going to talk about FES, which is the SAGES tool, and this is much more along the lines of what we see with the FLS curriculum. So it's a packaged deal. It comes with an online curriculum with 12 modules covering all the basic things that were outlined, or all the things that were outlined really in the flexible endoscopy curriculum. Basic stuff about the endoscope, pre-procedural, peri-procedural issues, sedation. It goes through upper endoscopy, lower endoscopy, understanding of anatomy. It goes to advanced techniques, ERCP, management of complications, and then advanced techniques like tissue biopsies and other endoscopic therapies. The skills curriculum. So this is what's really missing. And so there isn't a specific skills curriculum that goes along with FES. We have a test that says this is what proficiency is. And then we have guidelines of how to get there, but it doesn't say when do we get there. So unlike FLS, where we can go to the box trainer and just practice the tasks until you meet the time and precision criteria, this is basically saying practice until you're good enough or until you're proficient. And that's where we don't really know. Part of this is because the assessment tool is part of this is because the assessment tool that they use, that we're going to talk about next, is a virtual reality simulator. It's expensive, costs around $100,000. It's not widely available, and so people can't use that to just practice everywhere. So different institutions have things like low fidelity simulators, a box that you can put a pig colon into and tether it down with some clips. They have high fidelity simulators, some VR. Some places have VR simulators. We have one of those. Some training is done purely clinical, so you just do an endoscopy rotation and get all of your experience there. So they needed to keep it flexible so that every program could figure out a way to get there, and that's really what's in process. Now, responding to that pressure, the company that they used to develop the assessment, so the endoscopic trainer company, Symbionics, obviously took what they knew about the test and they put it into a curriculum. So for a reasonable $10,000, you can buy this skill set that will prepare you for the FES exam. Kind of like FLS, it's just, again, not available to everybody and costs a fair amount of money. So talking about the actual assessment, so this is 5 tasks that cover what they have deemed to be the core of endoscopic skill. So when they deconstructed procedures, they felt that endoscopic navigation, mucosal evaluation, targeting, retroflexion, and loop reduction were the core maneuvers necessary to define proficiency in endoscopic skill. And they went through this whole process, just like FLS, to validate this, to show that it was reproducible at different institutions, and to determine what they consider to be a proficiency standard. And these are the tests. So this is what we get. It's just little videos and clips and pictures. So navigation and orientation. So doing a virtual colonoscopy, and every so often you get a little chest piece that you have to match with a shadow on the screen. So it tests ability to navigate and also to orient the endoscope along the way. There's a loop reduction task. So task 2 is going through, again, doing virtual colonoscopy and being able to visually identify loops as they occur and then navigate through them, to reduce them and navigate through them. Task 3 is retroflexion. So this is being able to retroflex and then identify and target something. Task 4 is mucosal inspection. So this is a withdraw task. So like colonoscopy, the endoscope is inserted, and then on the way out, finding these little targets and fixing them in the field of view to verify that you've identified them. And then task 5, which is biopsy. So this is acquiring a target and being able to use an instrument to physically target and biopsy the object. That's the 5 tests. It's for testing only. You can't practice. You can't do a dry run and see if you're at proficiency. And this is really, when we talk about the modern view, this is what's really still in evolution. We're trying to define what it takes in terms of inanimate training, VR training, or even clinical training to reach these proficiency metrics. And that's why Gage's tool is important. As of this point, the pass rate for FES is 80%. So it's going to be a challenge. So the American Board of Surgery, what are we looking at next? So what have they changed? This is going to go back and look through the changes they made and where we're headed in terms of certification. So in 2008 to 2010, they introduced or required ACLS, ATLS, and FLS for certification. In 2012, they require operative and clinical performance assessments be done as part of the training program. Again, a way of assessing proficiency. In 2014, they require the flexible endoscopy curriculum and FES. In 2016, they issued a statement on surgical education redesign, basically saying now is the time where we're going to move forward on this, that they envision a process or a training paradigm of a core plus system, so core general surgery plus additional experience in a number of areas, and that the focus of this kind of paradigm is shifting towards learner-dependent education with competency-based assessment tools. So this is moving away from the standard of case volume and hours spent. So it's not necessarily going to be 4 or 5 years or 6 years of training, but proficiency-based. So when you can meet those proficiency goals. They're going to help with faculty development so we can be better teachers, so that we can be better evaluators of performance and do better at providing people feedback to help them progress through that novice to expert transition or novice to proficient transition. And they're going to continue to change the curricular standards. And this is really, that's where SCORE falls in, so we're all familiar with SCORE now, standardizing what's expected of a general surgery trainee. So what's next? I mean, where are we going? So we've seen FLS, ATLS get folded in, requirement for operative and clinical assessments get folded in. We've seen FES now. And so what are some other things that are out there that potentially could get folded into this whole process and meet these objectives of proficiency-based or proficiency-driven education? FES. So this is energy. We all use energy regularly. This is a curriculum that was developed sort of simultaneously with FES, also done by SAGES. It's available. It's a cognitive curriculum just talking about energy, about different types of energy, monopolar, bipolar, ultrasound-based energy, microwave, talks about fires and OR safety, all kinds of stuff. It's available. You can buy a voucher already. They validated it. It's just not required, but very, very reasonable to think that could be. Fundamentals of robotic surgery. So a new technology, it's different. We're trying to figure out what to require, what are the proficiency metrics before people start folding it into their practice. This again is surgeons going through these processes. It's kind of a little different than, kind of in the middle as far as practicing surgeons and trainees. But also, it's out there. The curriculum has been set up. They're working on validation right now. So the tools are there, and they have, at least the latest data I have is that they solicited beta test sites, 15 beta test sites in 2015, and they're probably a couple years out from having this formally launched with validated assessment tools. So defining a standard of proficiency in robotic surgery. What about just ultrasound for surgeons? I mean, the ACS has had this ultrasound for surgeons course for a long time. It has a lot of the same characteristics: online curriculum, manual skills training guidelines, assessment metrics. And ultrasound is one of those things that hospitals are trying to figure out how to assign or to privilege people in, because point-of-care ultrasound is so easy to get, and yet we really don't have a way of saying that people are proficient in its use. Another easy one to see getting folded into all this. This is one that's in development. Again, maybe it seems it's a little different in terms of a general surgery topic, but fundamentals of vascular and endovascular surgery. I didn't know anything about this, but you can find it. You can find easy information on it. They're following the FLS, FES models for development. They already have simulators, both physical simulators and virtual reality simulators for endovascular assessment. They already have open vascular surgery models looking at technical skills that correlate with, technical skill assessments that correlate with performance for open skills. They started validation, or they have some basic validation testing, and they're starting with beta testing. Again, moving along that FLS, FES pathway towards determining proficiency standards for core knowledge and skills in vascular and endovascular surgery. And I mean, does that apply to us as general surgeons, not just vascular surgeons? Well, according to SCORE, right, the national expectation for general surgeons, it still is. As of this year, our chief residents are expected to have core procedural knowledge in doing things like embolectomy, thrombectomy, and a FEMPOP bypass. So is it reasonable to think that the ABS might require you to have core knowledge or proficiency in basic open and endovascular skills? Yeah. Vascular, or for the venous diseases, they expect chiefs to know how to insert a venal cable filter. So I'm going to wrap it up by looking at what's possible. And so we've seen the way this evolves, and a lot of times around technology. It's easy to see how this progresses to the next level in laparoscopy for advanced techniques. Looking at things like laparoscopic bowel anastomosis, more complex laparoscopic task. And there's lots of divisions that do advanced laparoscopic procedures. You could envision sort of subsets of an advanced laparoscopic training platform for any of these. And then finally, fundamentals of open surgery. It brings us back full circle, right? Which is maybe we're going to start developing ways to actually verify proficiency in open surgical techniques. When I trained, I was going through this. I was reflected a little bit on my brief sort of history of this, and so I gave a grand rounds in 2004, I think it was, talking about why we should solely do lap appies as compared to open appendectomy. That was in 2004. I was sort of in my career, and the data that was coming out in kind of doing laparoscopy in a lot of new directions. And I laughed because Dr. Holcroft, to sum up his comment at the end, was basically stated, this is ridiculous. Open appendectomy is the gold standard. This is ridiculous. But here we are in 2017, 20 years from the launch of FLS, which was intended to help surgeons incorporate laparoscopy into their practice. And now our trainees graduate with probably more laparoscopic experience than they do, to some degrees, with open. And we look at things, it's easy to see how we could have a fundamentals of open gallbladder surgery come down the pipe. Because of our trainees, how many have done more than 10 open gallbladders? Raise your hand if you've done more than 10 open gallbladders, right? It's just, there you go. In the late 90s, open gallbladders were more the norm than laparoscopic, and now we almost never do them. There you go.
Thanks, Jonathan. A wonderful summary of the direction that surgical education is going. He went by with just one single slide there, the professional activities, EPAs, Joe, what's E stand for? Not enhanced, measurable, something, professional activities. The idea behind it is to if you can imagine this, mark down everything you're supposed to know in surgery into specific events and develop a testing for each of those events to see whether you're competent in it. You start making this list up, you pretty quickly run into the hundreds, if not thousands, of activities you're supposed to do. And so therein lies the rub, is how many of these can we pull off? But wonderful summary, particularly of the endoscopic procedures moving forward.
Yeah.
Scott.
Johnson, I really enjoyed that. You certainly had a front row seat on many of these training issues, the challenge of standardization, certification, transition from open to laparoscopic to endoscopic. And I think we've just heard the issue framed. There has got to be a balance between the enormous amounts of time and money you can spend on training versus value. And so I think now is sort of the time we need to really think very hard about the true value, the cost effectiveness, the efficiency of the training. Yeah, we've shown that training works, it helps, but there's a limit. You can only do so much. There are only 24 hours in a day. There's only so much money in the department budget. You could spend a fortune on simulators and stuff like that. So the challenge is for folks like you, experts like you, to truly help us identify value and efficiency in some of these training programs.
Yeah.
And I don't think we're there yet. I think that's the next challenge for us. And healthcare resources will be, by necessity, limited. Healthcare inflation cannot continue at the rate it's been going.
So there's,
and our training costs are all part of it.
yeah. I had originally I have a bunch of slides and I have all the data on all the costs that are associated with these things. And you raise a whole lot of good points, of which it's just, and we can spend hours talking about these. But I'm going to try and answer that or sort of respond to that question in maybe a couple ways. The first is we're not there yet, and the current paradigm is going to paralyze us in terms of moving forward. For each of this, for FLS, it took 7 years to develop. I mean, that was with a champion, somebody who was really motivated to do this. And same thing for FES. So he constantly was pushing. So Jeff Marks was constantly pushing, and it still took 7 years to get there, to get the buy-in and to get everything else. And so it's a long process, but the bigger piece, the bigger, I think, challenge is that very first sort of study we looked at, the meta-analysis, is that we had the effort of a whole lot of people. I mean, 609 studies done looking at simulation in healthcare. That's a huge amount of sort of effort and resources and time spent for the purpose of showing that a training program worked. The problem is that there's no unification there. And so if you were able to take that effort and the money that was spent there and channel that into true sort of to single studies that really look to move the needle, we could make it happen. But the problem is you got to convince people that it's more worthwhile, instead of you publishing a paper for your, to make promotion or to justify merit or anything else that doesn't really contribute something novel, that you should jump on board with a project, with a group project to actually move the needle, to define value. So we don't know. So there are a couple things that came out of that study that distributed practice makes a difference. So if you do a single training session versus distributed practice, that's better. Distributed practice is better. And having a mastery tool is better. So instead of just saying practice this and get better, if you give them objective criteria that they should work towards to develop sort of proficiency or mastery, that's better. Those are the only two things that really came out of all of that data. So a huge amount of wasted effort there to show the same thing that was proved in the first 5. And that's where we need to get. So we could have answered those questions in terms of value. Do we need 5 sessions or 7 sessions? And this all then ties into cost, right? How do we make it cost effective? If we can get 90% of the way there with 10% of the effort, but it takes a huge amount more to get to 100%. Why not just say, the value would say, great, let's cut this way back and do this. The way that the programs are coming up now, they're expensive to develop, they're expensive to host. And so FLS and FES, just the cost with those. So the cost of initial certification is like a $400 or $600 application fee plus a $1,200. That's just for the qualifying exam. And then the certifying exam is another $1,300. And then FLS is about $600. And FES, once the grant expires, is going to be about $600. And FUSE is about $300. That's just an online multiple choice test, about $300. ATLS, I don't even know what ATLS costs, if anybody knows, right? It's expensive. You think about all the rest of this stuff. So you're talking about maybe if we embrace open and endovascular surgery training, kind of a core knowledge for everybody. That's going to be another $600. You're getting nickel and dimed to death, and we need to figure out a way to provide proficiency metrics that people can be expected to reach. We got to figure out a better way of doing it. We got to pull resources, and we got to figure out a way to be sort of maybe a little more altruistic, working towards improving surgical education or improving the training program or the global training in the U.S. rather than focused more on individual efforts to improve our own individual career, our individual advancement, our institution stuff.
Well, you can't just blame it on the aspirations of
no.
future faculty.
No, I'm saying it's a paradigm. It's a
medical, educational, industrial complex.
Right.
Kind of led by the American College of Surgeons and American Board of Surgery, perhaps, that supports this kind of inefficiency.
I would fully agree with that. So actually, I'm part of in my own personal experience, I'm part of the curriculum committee for the ACS Education Institutes. And so one of the things we tried to do was develop a standardized curriculum in central line, right? This is central line. Everyone's doing this for 10 years, 20 years. It's well published. All the data's out there. It makes a difference, blah, blah, blah. The problem is that everybody has their own program. And when you sit down and you ask, hey, will you give up your program and use this program? Well, no. And then the program that gets selected who wanted to host it wants all their branding on it, so they wanted to say this is my university and everything else. So that was just one of it, getting some buy-in. We got past that. The problem is then who hosts it? Who ultimately kind of pays for it? And the American College of Surgeons, they're reluctant. So the organizations are great to say, hey, we want standardization in this. But when we said, hey, why don't you host this as an ACS program, put it on your website, let's make it free, we'll do the work, blah, blah, blah. They won't do it because they don't want to be responsible for copyright stuff. There's just a lot of other pieces that go into it. They don't want to get tied up in what simulator they're going to use or they're hands off. So even in these things where you're right. There's a lot of pieces to this that make it really hard, and that's going to be the biggest one to solve is coordinating effort to move the needle because right now it's going to move really, really slow.
I'm glad that we're talking about Norman speaking. I have to say, in my exposure to our residents in the middle of their trainings, in the mid-level or 3 or 4 years, I think that doing something as discrete and successful upper endoscopy is not a volume-dependent phenomenon. We take to it relatively innately, so I think that placing volume on it is totally the wrong thing to do. I think they get up to speed very quickly. My question is, our field now is moving like technology, so that the more we go, the quicker the field evolves. And we're talking about FES, but most of us who are deep in this are doing endoluminal surgery, right? So how do we reconcile the gap between where we are educationally to where the field is moving by people who are really kind of pushing the envelope to make sure that our residents finish? And we have even a fighting chance of kind of getting into it. If all you've done is FES, it's really tough to do the therapeutic stuff.
That's a hard. That again is a hard one, and that's going to be probably the main challenge is to ultimately developing criteria and training programs like something like FLS that focuses on the advanced techniques I'll be honest, I think it's going to be cost really to develop those are hard, and the effort. And when you're talking about a smaller group of people, and that if this is not core, so everybody's going to be sort of participating in the effort and all of this, I think that's where you're going to really have more trouble. So maybe saying that a different way is every general surgeon, you can make the argument, can achieve and should have some degree of proficiency in clearly laparoscopy and probably endoscopy, although even endoscopy is more, there's more variability in terms of who does it as far as general surgeons. It's not universal. And then when you get into advanced techniques of things like POEM and these endoluminal surgery, is that the numbers are even smaller. And so it's not going to be a universal requirement to say that everybody has to do complex endoluminal surgery, but it's going to be part of this, if you look at the ABS Vision for the Future, the Core Plus program, that's going to be the plus part. And hopefully those advanced sort of programs, so advanced MIS or advanced endoscopy and endoluminal surgery, is going to have its own sort of core metrics that they'll establish that will look more to address POEM. The challenge is already you have 14,000 people that are doing FLS, and it costs $600 to support that program as far as reassessing the questions, making sure that everything stays validated, blah blah blah, refreshing it to be current, and that when you have a smaller group, that gets a little harder to do. Maybe supported by industry. I'm not exactly sure how that's going to happen, but it's a complicated issue.
Let's have the resident role.
So it seems like in 10 years, I'm just going to be able to do my residency from a computer, going to a module, and getting all the training. It seems like now, even coming to operate, there's some people that are willing to teach more than others, because I understand that there's this need to do more and more cases. How much do you think that's really going to change ultimately what I just paid, like $10,000, I just take a bunch of tests, and I'm not going to need you?
So there's an element of that there's an element of that I think is going to happen, and there's part of that that doesn't make any sense. So and what I mean by that, right, is that to truly learn surgery, you have to do surgery. Is that there is no simulator for people, and so clinical experience is a huge part of that. But like FLS and FES, the best really to really launch those is that you can do this. You can do it with a high school student, right? You can put a high school student on the FLS trainer and have them practice those skills and develop they can develop technical efficiency or proficiency in doing those skills. It doesn't give them the clinical judgment. I mean, a big part of this is judgment too. It doesn't give them the judgment of how to do the operation in a person, and this is the way I kind of explain it when I'm in the operating room, is it doesn't help you do the lap chole, but it helps you focus on what's the important step. What am I trying to accomplish at this phase of the operation? So that you're not thinking about, oh, how do I tie the knot? How do I move the hook from the trocar to the patient? You're focused on, where am I putting it? What's the next step in the operation? What's available to be cut or dissected or anything else? So it's thinking about. There's some data on this which didn't talk about anything. Is when you do an operation, when you watch a video of an operation and you ask an intern what they're watching, what's going on in the operation, or what's important here, versus you watch the attending, they're focused on two totally different things. And we see that practically in the operating room when you do an open inguinal hernia and the intern is there and they get to tie the knot. What are they thinking? They're like, okay, how do I tie the knot? I'm like, oh, do I hold it in this hand? Do I hold it in this way? And they're focused on putting the knot down, not on, okay, where is this knot being placed? How is it securing the mesh? Where are the shortcomings? No, I understand. But so to answer your question, it's the first phase of this is going to be more of that online. So from efficiency, and this ties into what Dr. Hundal said too, if we're trying to get efficiency and value in training, to have you spend a period of time doing FLS where you can do skill after skill after skill after skill after skill. There's no turnover time. The only turnover time is putting the pegs back on the things, is reloading the cutting task into it. Is you can develop core skills, core sort of technical abilities in that trainer more efficiently than you can showing up for 5 lap choles and doing 5 lap choles, right?
I know Howard's like, well, Rich will go next, but one way to think about it is volume performance is real. It may take you 100 times to do an operation before you get it down pat. The idea behind simulation is it's only going to take you 20 times to get it done pat. That you're going to learn what you would learn in the first 80 doing a simulation skill, and therefore you can become proficient at it in the shorter amount of real operations. And so that's the dream of simulation.
Right.
Is it minimizes our time.
We don't have
it
good
works to a degree, but still not 100%
yeah.
sure.
It's not perfect. There will always be clinical
Rachel, you wanna finish
training.
up the last question?
Yeah, so we've talked a lot about the large volume of things graduating chiefs are going to be responsible for knowing how to do, even when we maybe never have done one of these operations that we're supposed to be proficient in. So is there still more talk about moving to a 3+2 model? Where are we at with
No. The reality is that what John has said is exactly right. And it's great to be on the board of whether you can shorten it from 5 years to 4 years and then do the plus. Right now the sentiment is a little bit more on the line of your 5 years is the core, and the plus years is the 2 years of fellowship that 80% of you end up doing. I mean, that's the current concept of the core plus. That's sort of what you're all doing now. I mean, the residents have all voted with their selections. 80% of you wanted to do fellowship training. And all of you respond that the reason you do fellowship training is because you feel incompetent, uncomfortable, not ready at the end of 5 years. And everyone in practice, which is where the college comes from, is yelling at the board and yelling at the college, you're not training residents well enough. We don't have a good enough product. There's something wrong with your training sites. You're not training us a good product. And people are responding to it. So this is all an effort as to say, okay, we're stuck with the 8-hour work week. We're stuck with the different demographics of the training population. We no longer have in-house house staff that live in the hospital. How can we train a competent surgeon in that environment? And this is an experiment. How about the next step in it? If you take the best, I'll finish up with this. If you take the ultimate example of entrustable professional activities, EPAs, it's practiced in the Netherlands. Now, here's what they do there. Only certain surgeons are the teaching surgeons that measure your ability to perform a technique. Not every surgeon does. You get a special dispensation to be the training surgeon who evaluates residents and gives them their scores. They do that because they know it takes more time, and it takes more effort, and so they diminish the amount of clinical work they have to do by being only specific surgeons can evaluate residents for entrustable professional activities. And they've documented every entrustable professional activities they have to do. They can do it because there is a small country, smaller than most states in the United States, entirely nationalized healthcare, entirely single-party care, and any rules that's made by a single entity are practiced in every environment. Now, if you think that's going to happen in the United States, take a really deep breath and pay attention for a while, because that's unlikely to be the scenario that we're faced with. So we have to find some other ways, to deal with this sort of problem. I know the hour is very late. Jonathan will stay up here and answer any questions. Thank you all for staying here.